Approaches to the acetabulum. I'm going to do this relatively quickly with the time remaining. I would say that for the recertification examination, I would look at this page or slide number 185. It summarizes the approaches to the acetabulum, the indications, and the structures at risk, ranging from the anterior approach, the extensile Coker-Langenbach, the extended iliofemoral, and then the modified stop approach to the quadrilateral plate. More prevalent in the trauma world. We'll just go over some of the questions to wrap this up. Which of the following structures exit distal to the anatomic landmark seen in figure A? The sciatic nerve, the superior gluteal artery, the piriformis, the inferior gluteal artery, or the obturator internus. And again, the arrow points to the ischial spine, which is the attachment site of the sacrospinous ligament, and again divides the greater and lesser sciatic notches, as well as the origin of the obturator internus. Just again summarize the southern and Coker-Langenbach approaches. It's basically identical to what we talked about regarding the approach to total hip replacement. So I think we can go over this relatively quickly. No internervous plane. Most of this is largely a repetition, just a small emphasis on the ability to turn this into a more extensile approach. If you're going to be going more posterior with this, again, being cognizant of the structures at risk, which in this case, if you're doing posterior acetabular work, is clearly the sciatic nerve at this point. And that's emphasized on slides 198, as well as the potential risk of injury to the inferior gluteal artery and the perforating branches right here. The ilioinguinal, question 40, while dissecting the middle window of the ilioinguinal approach, a nerve is encountered entering the obturator foramen. Excessive traction on the structure, which would result in the following: lateral thigh numbness, weakness in knee extension, anterior thigh numbness, medial thigh numbness, or weakness in hip flexion. And the correct answer is, again, medial thigh numbness. This is, in fact, the region of innervation of the obturator nerve. So obviously that would be the correct answer. Excellent exposure. The ilioinguinal for the internal iliac fossa and the pelvic brim, quadrilateral surface, again, summarized on that excellent table that we pointed out before. Anesthesia. This is reviewed in the slides, and again the surgical approach and how to make this extensile at this point. We'll just finish up. We've got 2 more questions in the time remaining. Extended iliofemoral approach, question 23. A 32-year-old male sustains a complex both column acetabular fracture, and the surgeon decides to use an extended iliofemoral approach. The patient should be counseled that as compared with other surgical approaches, the extended iliofemoral approach has the highest rate of the following: fracture union, malunion, nerve palsy, corona mortis injury, or heterotopic ossification. And the answer to that is HO. Because of its extensile nature, it essentially has a high rate of HO, and therefore counseling and presumably prophylaxis should be discussed. As you can see, this is a rather extensile approach. It is sort of a fillet acetabulum open, gives excellent exposure to both columns, and obviously is indicated for these very severe types of injuries to the pelvis and acetabulum. Slides 17 and 18 discuss the approach, the superficial dissection, the deep dissection as well, and some of the technical aspects of going forward with this surgical approach, the use of drains, wound closure and the like, HO, and then the structures at risk, including the superior gluteal artery and vein and the sciatic nerve. And then the final is question 37. When performing an anterior intrapelvic approach to the acetabulum, ligation of the anastomosis between the obturator vessels, and which of the following vessels should be performed to gain appropriate access to the true pelvis, external, internal iliac, superior gluteal vessels, femoral vessels, or the femorocutaneous vessels. And this anastomosis is between the obturator vessels and the external iliac vessels, and again, to gain visualization requires ligation in order to maximize that. The indications for this extensile anterior approach include acetabular fractures, pelvic ring fractures, and provides access to the quadrilateral plate, the sciatic buttress, as well as the anterior sacroiliac joint. Patient is typically placed in a supine position, limb is straight free, and the operating surgeon is on the opposite side of the table. These are the incisions that are made and carried out. This is an example of the superficial dissection, and then the deep dissection getting to the origin of the rectus abdominis muscle being released and looking for the anastomosis between the external iliac and the obturator vessels, which should be identified near the superior pubic ramus and ligated as well. Dangers are many, including the obturator nerve and vessels, the corona mortis, the external iliac vessels, as well as the bladder, obviously indicating the extensile nature here.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.